Hello there. I'm very pleased to be with you in this online conference. I'm Dr. Asad Abduli from the Department of Anesthesia and Intensive Care of American Hospital 3 in Tehran, Albania. We'll discuss a very important topic regarding the inflammatory markers in COVID. As we know, this disease has been very challenging and we have struggled with our patients for the last 2 years. So I think that it's a very important topic that we should discuss. Everything started in Wuhan, where our colleagues began to see very unusual chest X-rays and CT scans of the thorax, and eventually, in November 2019, several cases of unexplained and strange pneumonia came to the hospitals, and it was a very increased number of patients with a very unusual increased rate of death due to this disease. And since then, the World Health Organization has been involved in monitoring the situation because the pandemic was knocking at the door. Of course, every one of us should be familiar with articles that we as critical care clinicians should read and be familiar with about COVID-19. Everything starts with the virus itself causing direct cytotoxicity to the lungs. But second, and most important, causing an hyperinflammatory syndrome, which by itself may cause very, very difficult pathologies around the organism, such as microthrombosis and eventually organ failure at the site of development. So the therapy itself must be oriented to the inflammation with anti-inflammatory drugs such as corticosteroids or tocilizumab, or making it, let's say, more easy for the patient with ventilation with high flow nasal oxygen or awake proning, which by themselves make the patient ventilate better. Of course, there are also many therapies oriented to the virus itself, such as the antivirus, remdesivir, or synthetic antibodies, and so on. But what is crucial in this disease is the hyperinflammation, which should be taken in consideration and never to be forgotten. Understanding the pathophysiology of hemostatic disorders gives us the possibility to give a better treatment or to disrupt this cascade in our patients. So, as you know, everything starts with the virus itself generating an excessive immune response, cytokine storm, which eventually will cause hypercoagulability and endotheliopathy, and as a result, hypoxia will develop, which will worsen even more these kind of cascades, and the body will eventually go through macrothrombosis or microthrombosis throughout its chain of vessels, and of course this may generate pulmonary embolism or ARDS at the end of the cascade. So the therapy should be focused to disrupt this cascade at some place. Of course, regarding this pathology, there were several articles and researchers who published day by day several findings from the studies that they have made on their patients. In the International Journal of Infectious Diseases in 2020, there was an article about the association of inflammatory markers with the severity of COVID-19. It was actually a meta-analysis of 16 studies and a total of 3,962 patients. Our colleagues there saw that the most useful markers to follow up the COVID patients were procalcitonin, C-reactive protein, ferritin, erythrosedimentation, plasma amyloid, and interleukin 6. So they followed the patient with these markers, but of course the protocols differed from center to center because it was an unknown disease. So it is not that we had or they had a specific protocol to follow up. So they saw that the procalcitonin, the C-reactive protein, and interleukin 6 were more correlated with the evolution of the disease in comparison to the other inflammatory markers. Another article which was studying the metabolic outcome in COVID patient related to the inflammatory and clinical inflammatory condition and the clinical condition of the patients stated that in 165 patients, the inflammatory markers were evaluated in these patients, and they evaluated also the correlation with mortality as well. And they saw and they found out that interleukin 6 NLI and ferritin were correlated more with intra-hospital mortality with respect to the other inflammatory markers. Another meta-analysis which shows the importance of this topic is meta-analysis from our Chinese colleagues who evaluated 45 studies and a group of 8,719 patients, and the inflammatory markers and the relation to the gravity of the disease were studied and were evaluated, and the most loyal of these markers who were studied was C-reactive protein, erythrosediment, procalcitonin, interleukin 6, the white cell count, and the interleukin 10. These were shown to be, let's say, as more significant prognostic factors of the disease. In one article which was published in the American Journal of Emergency Medicine, our colleagues stated that the inflammatory markers were poorly predictive for the clinical outcome among the hospitalized patients with COVID. So they saw that the laboratory values drawn within 48 hours of emergency department presentation, though often they correlated with clinical outcomes, but they were not a specific indicator of the, or let's say highly predictive of which patients could have more bad clinical outcomes and so on, would require intubation, ICU, renal replacement therapy, and so on. The most let's say, common indicators that they evaluated was C-reactive protein, procalcitonin, and erythrosediment, which, let's say, among all the other inflammatory markers were the most predictive ones for a bad outcome or for a ICU treatment and so on. So these studies are very important because they help us to understand which inflammatory markers are to be seen, are to be followed, and when. So these studies go on. One meta-analysis of 32 studies with approximately 10,000 patients concluded that there was a significant association between lymphopenia, thrombocytopenia, and elevated levels of C-reactive protein, procalcitonin, D-dimer, and lactate dehydrogenase, and the COVID severity. So these results had a potential to be used as an early biomarker to improve the management of COVID patients, because of course we could identify high-risk patients and probable outcomes more early. Anyway, these, let's say, protocols change every day. These studies evolve every day. Generally, we should make inflammatory marker checkup regularly for these patients, and we observe that in the first 7 days we have a mild elevation of lactate dehydrogenase, the liver enzymes CK or CKMB. These may be early markers of the disease, and in the second week of the disease, we begin to see that thrombocytopenia, increased interleukins may occur, and when the patient is, let's say, more than 14 days with COVID, we see a total leukocyte number increasing, and lymphocyte and platelet counts be, let's say, markers of poor or good outcome of the disease. In our experience, we follow up the patient with D-dimer level, ferritin level, fibrinogen level, normal blood count, LDH, the NLI index, and C-reactive protein. In advanced phases, and in some specific cases, we even measured interleukin-6 and interleukin-1 for the cytokine storm, especially in the cases with clinical deterioration. We at the Department of Anesthesia and Intensive Care in American Hospital, we treated more than 250 patients suffering from COVID-19. We followed these patients in ICU, and they were followed every day by D-dimer, blood count, fibrinogen, ferritin levels, LDH, C-reactive protein, and procalcitonin. As I said above, the interleukin-6 measurements were performed in very specific cases, 8 cases to be correct, and we managed the therapies according to the results. So according to our experience, the C-reactive protein, procalcitonin, and ferritin high levels are considered to be markers for a poor prognosis. Of course, lately the neutrophil and lymphocyte index is of great importance for this prediction. So as a conclusion, we may say that biochemistry labs are very important in diagnosing treatment and in the prognosis of patients suffering of COVID-19. And the collaboration between the laboratory department and other departments is very, very fundamental. In our experience, the most used inflammatory markers are C-reactive protein, procalcitonin, erythrosediment, neutrophil lymphocyte index, D-dimer, ferritin, and fibrinogen. And as I said before, the interleukin-6 measures are reserved only for specific cases in which we suspect the cytokine storm. Thank you very much for your attention, and have a good day.